Sure. Good morning, everybody. Let's see. I saw some of you already, but for the sake of people who may be on the phone listening, Oscar Arana.
Here.
Hello. Dr. David Bangsberg.
Here.
Kirsten Isaacson.
Present. Steph, you're much quieter than David.
Thank you. Is that better?
Yeah.
Sometimes if you hold the mic in your mouth. Brenda Johnson.
Here.
Dr. John Santa. Don't see him. Rosenda Shippentauer. I see you.
Rosenda, you're on mute.
Okay, here.
Great, thank you, Rosenda. And Zeke Smith. Okay, so we are missing Dr. Santa and Zeke Smith, and we'll let you know if they pop back on at some point.
We are expecting Zeke, I hope.
I believe so, yes.
All right, well, we started at 8:31. We'll give it a few minutes. All right, John just joined. Welcome, John. And there's Zeke. Hey, Zeke. Welcome, Zeke. All right. We got a quorum. Well, welcome, everyone. Again, great to see you all here. Hope you had some joy over the summer as we start the beginning of September with our Oregon Health Policy Board meeting. Certainly challenging events happening here in Oregon, particularly in Portland. And I'm sure we're all concerned about Portland being in the news for the violence on our streets that is replacing peaceful protest. These protests are around central themes around anti-racism, which is our most important determinant of health equity, which is, remind us all, an organizing principle for all of us at the Oregon Health Policy Board and also the Oregon Health Authority. And during this time of chaos and uncertainty, I hope to ground the board, policy board, and everyone at OHA and the important steady progress we make in our work together. Those before us accomplished the Oregon Health Plan and CCO 1.0, which were nationally leading accomplishments that the entire state is proud of. Under our watch, we accomplished the policy framework for CCO 2.0, which prioritized health equity and the social determinants of health, which are so important. And this is what our community cries out for today, for health equity, through addressing the social determinants of health, namely racism as the most powerful social determinant of health. You may not see signs that say health equity or social determinants of health, not these exact words, but those of us who are health policy geeks know that we're all talking about the same thing, both on the streets and in our work together. And I also want to recognize during these uncertain times, just ground ourselves in our collective progress in responding to COVID-19. You know, the Oregon continues to have the 5th lowest infection rate, the 7th lowest mortality rate in the country, as we begin to open up the economy with evidence-based policies and also recognize the impact of the epidemic on those most affected, particularly Black, Indigenous, and other people of color. And this is why we prioritize stakeholder reports during our last meeting. We'll do so again today to understand the ongoing impact of COVID on those most impacted. And we look forward to hearing from Central City Concern, the Mid-Columbia providers, and the disability community. And also pay attention to our immediate and long-term changes in behavioral health integration, which we'll hear about today, where the discussion amongst us as a board, as well as public testimony, really redirected Oregon Health Authority to go back to our basic principles. And this is all this important work is done during unprecedented fiscal stressors on our state. So in this time of chaos, and certainly that is this time, we remind ourselves of the good work we do together in partnership with OHA and in partnership with the public. And with careful and thoughtful deliberation, and that we are addressing both emergent issues, but also really paying attention to the long game. So thank you all for being here today. I look forward to our meeting. Today we will have an update from Director Pat Allen on the COVID-19 status in the state. We'll revisit the short August legislative session and how that impacted OHA's budget and programs. We'll talk about Healthcare Workforce Committee and their update from earlier this year. We will review member appointments to the Oregon Health Plan Quality Metrics Committee. We'll take a break, continue our stakeholder presentations looking at the impact of COVID-19, and we'll have public comments following the stakeholder presentations. If you have a public comment, please text Michelle at 503-551-3881. That's 503-551-3881 to sign up for public comment, and please sign up before the mid-morning break. Also, one other change is the chat's only enabled for the board members to communicate with the staff during the meeting. So with that introduction, I would like to welcome Director Pat Allen for our update.
Great, thanks very much, Chair Bangsberg and members of the board. A few things. I know you've gotten the two most recent weekly reports, and so I'm not going to go over those numbers in detail with you today, but I do want to talk about a couple issues around those numbers. As Chair Bangsberg remarked, we continue to have one of the lowest infection rates in the country and one of the lowest fatality rates. Well, one of the things that's interesting to me, there seems to have, there's this pattern going on now of states going through some horrific kind of a crest of cases and then falling back down. And if you look at the 10 lowest states in terms of their most recent infection rate, just over the past 7 days, we're one of those 10 lowest states. But today, the other states that are in that list are New York and New Jersey, Connecticut, Massachusetts, places that had terrible rates of infection back in the spring. We seem to be kind of hanging in that pack while having gone through an increase in cases without having to have gone through that horrific level of disease, and I think that's really a testament to the governor's quick decisions around closing things down back in the spring, and the fact that in the main, and with some exceptions out there, Oregonians have been doing a pretty good job of the basics of living with coronavirus, around wearing masks, maintaining distance, washing hands, all those kinds of things. So I'm really pleased with that. The metrics that we're really focusing on now are the school metrics. What does it take for there to be some amount of in-person education? And that those metrics, you'll recall, are generally 10 cases per 100,000 population over the course of a week. And if you think of that in terms of a statewide number, that's about 60 cases a day. Right now, we're running at about 225 to 250 cases a day, down from 350 at our peak. There's also then and it also requires there to be a statewide positivity rate of no more than 5%, and then a similar 5% rate in the county in question. And these metrics, other than that statewide positivity, are all measured at the county level. There's also a K3 metric that's higher. It's 30 cases per day, so that would be about 180 cases a day statewide. And we're really increasingly beginning to approach that metric. There are today, I think, 17 counties that, as of our updated metrics yesterday, met that 30 cases per day metric. There are also 5 counties now that meet the 10 cases per day metric. We've not been at the 5% positivity rate for the necessary 3 weeks yet. So those counties won't be able to go into full K-12 in-person education, but we're getting closer. That 17 counties is up from 15 last week, up from 11 about 3 weeks ago. And so we continue to be making sort of step-by-step progress down that path, and that's very, very encouraging. That said, I don't think anybody should mostly expect full-on 5-day-a-week in-person education at either of those levels, because we also have extensive guidance that we've worked on jointly with the Department of Education around distancing and all the other requirements to be able to operate schools safely. And so most, at least larger districts, are expecting there to be some kind of a hybrid version of kids in school for some number of days a week, short of 5, and being able to rotate kids in and out and accommodate space that way. So we'll keep an eye out for that. I want to turn a little bit to some equity elements of the response to coronavirus. The legislature did, not in the short session, but in the e-board before that, approve the equity fund that we requested about 3 months ago to respond to needs of specific heavily impacted communities around the state. The deadline for applying for the grants for that fund, it's a $45 million fund. The deadline for applying for grants was yesterday. As of early in the day yesterday, we had about 125 applicants for that. We would expect a fairly large number would have come in at the deadline, but we don't have the most current number. So that's going to be a big step toward being able to meet the specific needs of communities that are particularly struggling with effective quarantine and isolation, which is one of the challenges that we've had in trying to fight the pandemic. The money needs to be spent by the end of the year, and so I really wish we'd had it 3 months sooner than we got it, but we're grateful for the ability to do that. We also now have contracts with over 100 community-based organizations around the state focusing on being trusted partners in disproportionately impacted communities that can often be more effective than governmental entities or others in being able to do that work around contact tracing, case investigation, and facilitating effective quarantine and isolation. So these pieces will now begin to work together now that we've got the resources available for that. You're going to hear, last thing I'll talk about is the budget. Just briefly, you're going to hear a longer update from Dave Baden on the budget. We've now gone through a round of cuts to the current biennium budget. One of our principles in assembling those cuts was to hold our equity investments harmless as a part of shifting resources toward equity work. In the main, that meant protecting from cuts our CPOP program, the Equity and Inclusion Division, other investments we make in sort of the human infrastructure to do that work. We're taking the same approach as we build the 21-23 budget, among other things. Part of what Dave will talk about is the agency request budget that becomes public today. And that's got some pretty significant cuts in it. As we look at cuts to the budget, either the required 10% that are part of the agency request budget or any other scenarios, understand that those are the kinds of cuts that we propose because we have to, not because we think they're a good idea. And when you start getting to some of these levels of cuts, there are just, it's a choice of which horrific thing do you do and which horrific thing do you not do. They don't represent in any way, shape, or form anything that we think is good public policy, good equity policy, good health policy, anything along those lines. I think that's mainly what I wanted to give you an update on today, but I'd be happy to answer questions.
Questions from the board?
The most complete report ever, evidently.
Well, Pat, I want to comment on the school situation. I just been in the discussions at the state level, also Portland Public School District, and I really appreciate the thoughtful, careful, and evidence-based approach to this really difficult decision. Just corresponding with my colleagues at University of North Carolina and other universities as they went through opening and then closing, the sort of administrative effort and chaos to change gears quickly really is distracting from both providing either high quality remote education or high quality in-person education. And so I think the state's approach, certainly Portland Public School District's approach of having clear metrics, going cautiously so you don't have to change gears all of a sudden is really, really important. So I would just want to compliment everybody involved in those discussions. I
appreciate that. Our daughter is at Notre Dame, where they opened for a week and closed for 2 weeks and are going back actually to in-person education tomorrow. haven't gotten their case rates down. And you're right, the whipsawing is pretty challenging. We think that in education and really everything else, the key really is you can do a lot more when you get the rate of disease in your community down to very low levels. That's been the clear learning from what's gone on in a variety of fronts in Europe, and so that 10 feels like an impossibly small number, but we really feel like that's first of all science and experience based, but that it's just a critical component to be able to open schools and open other things without things getting away from us quickly.
John?
Yeah, Pat, I just wanted to say how effective I thought it was in, I think, the communications last week for the state to emphasize the example of the 15 folks who got together for a reunion of some sort or other and ended up, infecting 300 folks at 5 outbreaks. I realize there's a tension in terms of privacy, but I think the public needs to hear, and that day, that example was just on every news, local news outlet, and I think the more of those you all are comfortable putting out there and emphasizing, the more this point gets driven home. Thanks for doing that.
I appreciate that. Thank you.
I want to say that I'm really happy to hear that OHA is now moving forward with more contracts with community-based organizations, which are more on the ground, being able to respond sometimes faster to some of what's happening with COVID-19. And then you mentioned that there was just RFP that closed yesterday, which we're now in September, and a lot of this money has to be spent by December. I'm curious about how fast will OHA be able to turn around responses, be able to actually get contracts on the ground, which would probably leave about, I'm assuming maybe a quarter of calendar year for folks to spend out what I think I heard was, I'm not sure what the amount, like, was it $4 to $5 million? I can't remember.
45 million.
45.
Yeah, it's a lot of money. I really want to compliment Leanne Johnson, Julie Johnson, and Oliver Vera, who are our core leadership team around the work on this fund. They have done an incredible job of getting a quick and yet thorough process on the ground. They've provided a ton of technical assistance to what are often very, very small organizations that don't have a lot of experience in this field. And so, as I said before, I wish we'd have gotten this money 3 months ago, or half a pandemic, as I like to think of it. But we've got it now, and they're doing a great job getting that money out on the ground as fast as we can.
I wonder if you could take a moment and speak to the process that OHA and the governor's office will be using around decision-making for the distribution of vaccine when it's available.
Yeah, thanks for that. We have a team that's beginning to design the community engagement that we will need to do around vaccine distribution. We're hearing a lot of things out of the federal government that lack enough detail to know exactly what they mean. And what I mean is you could interpret them to mean that the federal government is going to give us part and parcel every detailed direction around exactly who gets vaccine and when and how. They have signed a contract with McKesson to create distribution nodes for vaccine around the state. And so it's possible that there's not a lot of discretion left to us in terms of prioritization. Nevertheless, what we want to do is have some broad and deep community engagement, really for 2 reasons. One is to help inform any prioritization decisions that we do need to make around that. But as, if not more importantly, really work closely with community around overcoming history around medical experimentation, trust of the medical industrial complex, if you will, and also try to deal with vaccine hesitancy to the extent that it also becomes a problem. I've heard the phrase used a number of times that a vaccine does not stop coronavirus. Vaccination stops coronavirus, and the idea that a vaccine nobody takes is not super helpful. So that's really the process that we're beginning to work on now.
Any other comments or questions for Pat?
Just one more, in a non-COVID related prioritization list for you, Director Allen, what is sort of top of mind, the kinds of things that you're working with the agency to kind of put us back on track in terms of our strategic focus?
Yeah, thanks for that. I would say the number one top of mind issue is our commitment to health equity in the long term. We just had a session with the agency leadership team last week to basically restart that work, where we had left off at the place where we had committed and recommitted to elimination of health inequity by 2030 as our strategic goal, really converting health equity from a value statement to the about the work that we do to being the point of the work that we do. And we had left off when coronavirus struck, at the point where we were really getting into hard conversations in a good way about, well, what's that mean? What does it mean to lead with race? What does it mean what are the things that we need to do to be able to really dig into that work? And so we've begun to come back to it now with a heavy dose of everything. We're not picking up where we left off, because where we left off doesn't actually exist in this world anymore. So much has changed on so many fronts since just the first of the year, which is really, it was about February where we left off, that we have to think consciously about where are we today and how do we pick up that work and how do we start doing it. But it informs so much of everything else that we do around CCO 2.0, around our budgets and investments, around how we structure ourselves to do our work, our relationships with local public health, with CCOs, with healthcare systems, all those sorts of things. And so to me, that's really the driving force going forward, and the work that I'm actually most excited to get back to, even while we're still dealing with all things pandemic.
Thank you, Pat. Appreciate. We want to front load me with Pat's comments because he had to leave the meeting for temporarily, and will join us later in the morning.
Good, thank you.
Let's go back to approving the minutes. Ask people to review the minutes and entertain a motion to approve. Any motions to approve the minutes?
I move to approve the minutes.
Second?
Second.
Did I hear a second?
Yes, Kirsten.
Great.
Second.
All right. All in favor? Aye.
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 Any opposed? And any abstained? Great. All right. Thank you all. Let's hand it over to Dave Madden, who will do review our budgetary items framework for OHA.
Thanks, Chair Bangsberg, members of the Health Policy Board. Again, I'm Dave Baden, the Chief Financial Officer here at OHA. I think we're getting slides up here momentarily. Well, first, happy Agency Request Budget Day. I know everybody marked that September 1st on your calendar. So as Pat had said, I would say this is really the first sort of formal public part of the next biennium's budget, is to get that agency request budget in place. And we'll talk a little bit about broadly between Jeremy and I what's part of that. And we still obviously have a long way to go, and the state of the economy and what the economic forecast is for the state will really drive also what eventually become the governor's budget later this fall and into the winter. And then as the legislature gets back together for the long session to deal with the next biennium budget, it's going to be, you know, those are never, you know, obviously easy, you know, but the, you know, the amount of reductions and things that are ahead of us is going to make, as Pat said, a series of very difficult and bad choices as we face a pretty big budget deficit for the state. So Jeremy and I will tag team a little bit this morning. And if you can go to the next slide. So just a quick reminder of sort of OHA's budget in context for everyone. So, you know, OHA as part of the current biennium that we're in is 17% of the state funds budget. And so that's, again, against general fund, you know, that we're 17%. Between OHA and DHS, it's, you know, nearly 24% of that state fund budget. Again, we're a big percentage of what the legislature has to deal with. You know, but as you'll see in the next few slides, you know, a lot of this is you know, federal matching requirements with Medicaid, and, you know, a couple of other drivers of our general fund budget. But you know, the amount of federal funds that we get make this a really large budget for the state. So next slide. So I'll put a series of a few graphs up here to try to add a little visual context to the budget. So this is just to give context. This is the entire total fund budget for the Oregon Health Authority. So this includes all federal, other funds, general funds that come to all divisions to run the budget. So the first that you can see, other than the very large orange Pac-Man that seems to be driving the budget, and that's the Health Services Division, and that is driven by Medicaid. So out of our 24B, that's with a billion, so 23,481 million would be 23.5 billion for our biennium, so just under 12 billion a year. 17.3 billion of that is in the driven really by Medicaid. And so that really is sort of our total fund driver is the Medicaid budget for the state. So next slide. So just driving that down a little bit to, you know, you can see the general funds by program area. And again, it's still driven by a lot of health systems division. And this, you know, this gets into, you know, sort of balancing the behavioral health components of the health systems division, which is a very general fund driven set of budget, especially the money that we give to counties for core behavioral health services. But then you could see the larger share that the Oregon State Hospital plays in the state budget. Again, there's very little of the Oregon State Hospital that is outside of general fund. We get a little bit of Medicare reimbursement, but it's, you know, we're precluded from Medicaid reimbursement for federal rules for the state hospital. Just to go through the OHA central and shared services and assessments. So that primarily funds a lot of the portion that OHA gives to the state for overall rent, utilities, other things, and other assessments. And then the shared services between DHS and OHA, including the IT services, security, a whole bunch of other shared things that when OHA and DHS split, those were the things that were left behind that we jointly fund. And then, you know, public health programs out of general fund, you know, is nearly $100 million for the biennium, again, driven by federal funds from CDC and other places that drive that budget. So next slide. Okay, so to get into the sort of the where we were as we got into the biennium to what the legislature just did last month. So as we were, you know, got our budget approved, you know, we had a couple of continuing challenges that we needed to face as an agency, and that fall 2019 is really driven by something that the legislature knew going into the biennium, that there were some revenue and expenditure challenges at the state hospital that they really pushed into the biennium to deal with in Rebalance. And so that Oregon State Hospital, $85 million in fall, is driven by challenges that we had talked about you know, with the legislature before. The rest of those are you know, sort of either more minor or driven by some caseload differences in the health systems division. And again, rebalances that we go through are really driven by caseload and other sort of mandatory changes, as well as some other items that we put forward. But then obviously the pandemic happened, and in the short session, there never was a final budgetary agreement to those things that we put forward in the fall. And so when the legislature got together last week to deal with you know, the balancing of this current biennium's budget, we also had those past challenges that the legislature needed to deal with. So you can see that the Oregon State Hospital still received additional resources in the August special session, just not as much as initially we had asked for and had put forward back in the fall. There still are some additional small challenges that the legislature potentially will have to deal with in future rebalance asks. But then you could see the big reductions that were put in by the legislature and across the board. So the largest on the health systems division, you know, that's again a lot of caseload differences and some reductions in a few areas, some CCO rate reductions that are part of that, plus some other things that we'll get to here in a second. So you can see grand total is that with both some positives and negatives, that the August 2020 special session took about $147 million out of OHA's budget for this biennium. So next slide. So just again, to put a little bit of this into context, so you could see that at a total fund level, again, just where each division within OHA, so the health systems division, again, was the largest sort of total fund reduction. That's sort of both general fund and federal funds that came from the CCO reduction, as well as a few other areas there. And then the other total funds within the health policy and analytics division in the state hospital. And again, so that $6.1 million in total fund reductions. So that basically is they are still having to take reductions, and as you'll see when I'll kick it over to Jeremy here in a second, of some actual position reductions that the state hospital is having to deal with right now. So the state hospital really was the only spot where the legislature asked us to do actual position reductions. And so we're going through a process of reducing around 21 positions in the state hospital, and unfortunately having to issue a few layoff orders, but ideally trying to find some homes for the people that were encumbering those positions. That was our only spot of an actual people reduction in the reductions that we received. So next slide. So this is just at the general fund level. You could see again, the health systems division is the majority of reductions. It's sort of a combination of CCO reductions plus some other caseload related things, and then the percentages that go with those reductions across the board. Again, I'll characterize you know, the reductions that we put forward as you know, as delays in a lot of either programs that the legislature asked us to start this biennium, delays in hiring, or in some cases not hiring vacancies throughout the entire biennium, to get to the level of savings. You know, there's you'll see in the next slides that Jeremy will go through, you know, there's just a lot of new and innovative programs that we're having to delay and slow down in getting to these reduction points. All right, next slide, and let me turn over to Jeremy to take the next couple of slides.
Great, thanks, Dave. You largely covered a lot of what I was going to say, which is that you know, we went through a 17% cut exercise this spring, and fortunately didn't have to realize that level of cuts in the special session. Largely, what the legislature did was really back off of investments that it made in 2019. So we kind of scaled back a lot of the new innovative investments that that we were looking forward to, but we're able to avoid the much more drastic cuts in the process. The one area where we are especially feeling the pain of a reduction this biennium is in the state hospital, where we lost 21 positions that were part of an administrative non-direct care unit, and we're busily working with individuals in that position, as well as with our labor unions, to try to find spots for those folks and minimize the amount of layoffs that we have to do. But that one is real. Many of the other reductions were through really delays or just backing out investments that were made. So most of what you'll see here, there were a lot of behavioral health investments made in 2019. And so that's where a lot of the reductions were made, because they sort of backed out those investments. So reduced funds for yet to be announced new contracts in behavioral health, and they were able to swap out some general fund for some federal funds. Delayed increases on the on-site inspection of in-home care agencies. So they were going to increase inspection schedule, and they're delaying that. Realized some savings from sort of standardizing mental health residential rates and the timing of that. And they were also able to swap out some other funds for general funds. That saves about $28 million. Next slide. They were able to realize some savings from a delay in rental assistance and wraparound services for a planned construction of some permanent supportive housing units. That's not going to be launched this biennium, and so they were able to capture the savings of basically a delay in those in that housing services being launched. Likewise, include some savings from a delay in the voluntary universal home visiting program, and then across the agency saw about $20 million in general fund savings from holding open vacant positions, and that was really agency-wide. And just to give you an example, we had about 35 positions within my division that were added, that were basically held, and we won't be hiring for this biennium. All right, back to Dave.
All right, next slide. So I thought it would be helpful to talk about something for a bit with this group, knowing the strong push and interest in CCO 2.0 and CCO rates generally. So to put this into context, you know, because we're moving into CCO 2.0, the legislature back in 2019 gave us the authority to do a one-time retroactive rate adjustment in the 2020 rates. And the legislature, you know, basically that was put into place because as we were going into CCO 2.0, where there were new CCOs or CCOs that were changing service areas, you know, there was an open period that happened between January and March of 2020 that then changed sort of the overall risk profile for each of those CCOs. And you know, the legislature had put in place that to do retroactive rate adjustments. So that's what we did. And because of COVID, you know, we really looked at what were the impacts of the CMS changes, especially to not disenrolling people during the public health emergency. And so the simplest way to think about this CCO rate adjustment was really for two reasons. So one, you could see in that second bullet is, is we are not currently disenrolling anyone from the Oregon Health Plan unless they move out of state or incarcerated. And so that really has changed the overall sort of member risk mix based on who those disenrollments have typically have been, sort of people that have come sort of in and out of especially the ACA pool. And historically, those people have been healthier and have utilized less services in the Oregon Health Plan. And so a couple years ago, when we were sort of going in the opposite way, CCOs received additional resources for the same reason. Basically, is that the acuity of the members were higher, so CCOs received higher rates at that point. Well, the opposite is true now, is that what's driving enrollment really is this not disenrolling folks. And so what that led to was about a 2% reduction in CCO rates. And again, that just differs amongst CCO by CCO. That led to really it's sort of a not arguably because of the budget driving this, it's really us matching the risk, the overall risk pool of the Oregon Health Plan into the rates that we receive. And that's really the driver of what we tried to do. I will say that, a couple of things. I mean, one, these reductions that are talked about here are, more than offset in the projected increase in CCO enrollment. Is that between the additional resources that CCOs are on a per member per month getting, it's more than what these reductions would be. And just as a quick reminder, during COVID, we stopped doing the withhold for the quality pool, which put a 4% starting April 1, put a 4% increase into CCO's bank accounts during their per member per month piece. So the 2020 adjustments ended up being about a $20 million general fund savings. And then if you just, to get to 2021, it's almost a simple math exercise, is that the starting point for 21 would be lower because we lowered the 20 rates. And so for the first 6 months of 2021, the legislature recognized an additional $9 million in savings. So the 2021 rates that were just delivered to CCOs this month are back. So this same acuity adjustment that I talked about before is no longer in the 2021 rates, is that there are just so many unknowns as we look into 2021, from acuity to utilization to, really the impact of COVID and treatment cost, the vaccine. There's just a lot of unknowns. And so we have gone back to a little bit more sort of a standard increase that's, if you get to the total fund level, a little bit lower than 3.4%, but pretty close, depending on sort of how you count CCO by CCO. Again, that's one big thing that the legislature is going to have to deal with as it gets into 2021. What do they want to do about CCO rates generally? And we've just started a budget group with CCOs to really dig into that, to try to provide some recommendations to the legislature on areas that the legislature could look at as it's looking for what will be some pretty big reductions in the future. All right, next slide, and then we're definitely some time for questions.
So as Pat and Dave mentioned earlier, we are today basically submitting our agency request budget. And so let me just kind of walk through what the process looks like. So throughout the spring and early summer, agencies develop their individual budget requests and then submit them today, first day of September. Then the governor and her budget team will work through those over the next several months. There'll be a lot of back and forth with the agencies, and then her budget comes out December 1st, and then basically the ball goes over to the legislature, and the legislature picks it up from there. This is a odd year, having a major recession hit us right in the midst of this budget process. So this spring, we were in the process of, I think, really fine tuning a lot of what we thought were really critical investments to really advance health system transformation. And so we have a mix of about 70 policy option packages, and a policy option package is basically a budget request, so something on top of what you normally would already get. And then we had a recession hit, and so we started to also walk through a cut exercise. And so what's going into the governor's office is basically, a couple of options on a major, two couple very polarized options of really critical investments there's gonna be very difficult to find funding for, and at the same time major reductions that really, as Pat said, there's really no good choices in there, and so it's a mixed bag of what's basically going in because of this weird time that we're in. The way the agencies have to put their budget together is they start with what's called current service level, which is basically just roll everything forward plus inflation. And then, as I mentioned, you have a policy option package for anything that new. It's a little bit of a misnomer because within we have about 70 policy option packages that we put forward to the tune of almost $500 million. But it's a mixed bag in there. Some of it is actually reductions in funds that we're asking to be backfilled. So an example is the Office of Health IT was largely funded by federal dollars. So Susan Otter's team, that was funded at a rate of basically a 90-10 match, meaning the federal government was covering 90% of it and the state was covering 10%. But those federal funds run out next year, and so we have a policy option package to backfill that with general fund. On the flip side, there's a whole bunch of brand new things in there. So, and we really prioritized equity and behavioral health as sort of the top two within that long list of 70 options. But there's things like trying to extend electronic health records for behavioral health as just an example of sort of a new program that we also propose. So you'll see it's a very wide range of things that are within the agency's request budget. We were tasked with also coming up with a 10% reduction list, and that, unlike I think what we saw in the special session, includes some real significant reductions. It's to the tune of about $330 million. But we're now actually being asked to go back and come up with the reductions on top of that in the 20% range, recognizing that they know they're about probably at least $3 billion short next biennium, and so they're going to need some significant cut options. So we're now going back and pricing out basically what those reductions up to 20% would look like. And I'll just say, you can find a bunch of vacancy savings one time, like we did this biennium. But when you start to get into 10, 15, 20%, these are really, really significant cuts. And so we'll be submitting those this summer as well. Governor's budget will come out December 1st. And then, as I mentioned, we'll go over to the legislature and we'll go from there. Happy to take questions.
Yes, we have just a time for a question or two.
I don't know how brief the explanation might be, but the question is about how much lead time we give CCOs in rate setting. I know that we've had this sort of a recoupment or a reconciliation process, and we'll go back, redefine rates, and have expectations around CCO performance based on lower expectations than what we may have originally stated. And so this is both a statement and a question. Over the last 8 years I've been connected to CCOs, I've seen that bouncing ball move between OHA and CCOs. And I'm curious in terms of this moment in time, granted the amount of volatility that's in the recession and planning from the federal match, et cetera, how confident are we in our current rate setting process, particularly in terms of the timelines for, giving as much notice as possible so CCOs can alter their investment plans?
Sure, thanks, Brenda. I'll take that. So Yeah, I think that this year, was both exceptional from what we knew we were going to have to do with a retroactive rate adjustment that that the CCOs were planning for, as well as the normal rate process that we go through with them on a year-over-year basis. The two were definitely overlapping, and it was difficult for I think for us and for the CCOs to really keep up with sort of the pace of things as we were making those changes. I think I think, Brenda, what you've laid out are really some of the reasons why we have engaged this a little bit of a longer term planning group with CCOs to think through what will be some challenging budget times as we talked about, and to limit any surprises as we go through the rate setting process. I think two things that I'm really interested in, as the CFO here. Yesterday was the due date for the CCO's Q2 financial submissions, and so that will cover the period of sort of the midst of the shutdown and really the dramatic lowering of utilization during that time frame. So we have sort of that drive down in utilization again, which we did not adjust the rates at all to take into account what in some cases was a 30-40% drop for a few months in utilization. So I'm just really interested to see sort of how the CCO financials have weathered sort of that piece, and also what we had asked the CCOs to really shore up their provider network during that time period. So that really is going to be a good driver of seeing where things are financially. But it is definitely a fair point of this has been a really hard time period. Sorry, Kat's joining my picture here. A really hard time for for all of us to do a little bit of future planning, and that really is the driver of the budget group that we're putting together.
I just would add that we had, as a policy goal in CCO 2.0, moving from annual rate setting to basically a biannual rate setting with an adjustment in between for things like change in risk in the population, to try to get out of, frankly, spending 6 to 9 months out of the year and rate setting processes. So we're still moving forward with that, and hope that provides some stability in the system.
Thank you very much. John, quick question,
Yep.
and quick
Yep.
answer. We're a little bit behind.
Yep, actually, I just want to follow up, Dave, on those last comments. I mean, we've seen from some of Jeremy's presentations, once in a lifetime, enormous decreases in utilization. And I think getting a sense of where those are, what's happening to that money on the Medicaid side, what's happening, in the fee-for-service side of Medicaid. So you've already mentioned it, but I just want to reinforce, I think it's very important from a transparency point of view to give the public a sense of what happened to that really huge amount of money on the Medicaid side, and challenge the private side, both Medicare and commercial, to do the same thing.
Yeah, thanks, John. Totally agree. And, we're do a quick analysis of what we just received, and happy even to give a quick report out to the next, OHPB meeting if that makes sense.
I would really enjoy hearing that update, especially with the highlighting of understanding which CCOs engaged or passed that money along to prop up providers.
Yeah. Let me just end with a comment. Thank you both, Dave and Jeremy, for their presentation. I think if you ever need help in any public forum or working with legislators to help reinforce the message that these investments are best investments towards economic recovery in terms of how we're managing COVID-19, I see the reductions in the public health division as we have increased needs for contact tracing. Hopefully, I know that you have CARES funding that helps a bit, but gosh, our best path to economic recovery is investing in managing this epidemic as well as we have and continuing to do that. So there's only one path forward. So please call on us if you ever need help making that argument. Let's turn over to our next agenda item, which will be introduced by Brenda Johnson. I would like to remind the board that this is an item that will require a vote, and also wanted to welcome David Robinson, the Executive Vice Provost from OHSU, and Julie Hanna, the OHSU Government Relations VP, who will be here to answer any questions about the Scholars for a Healthy Oregon initiative. Brenda.
Thank you. It's my pleasure to speak on behalf or to welcome our committee's presentation today. As you know, I serve as the liaison for this particular committee. And excuse me, in that capacity, I'm struck by the committee's attention toward the work that's both in front of us today, while also holding tension for really long-term investment impacts, particularly as we think about the investments in loan repayment and the human potential that we invest in clinicians and providers in our communities. So much like the introductions by Dr. Vansberg and Director Allen this morning, this committee spends a lot of time recognizing the critical nature of combating structural racism and advocating and advancing issues around health equity. We prioritize awards to people from underrepresented communities, those that possess a secondary language skill or may come from either historical or currently marginalized populations. So to that end, today you're going to hear a presentation from our staff and committee leadership that will really create a significant shift for the loan repayment program into the future. Not only does the shift support our board's prior recommendation around investments in behavioral health, it also requires a rule change that will make those eligible applicants and the opportunities for qualified mental health associates to apply for awards under this particular program. That both serves some of our health equity intentions that we've set as a board, but also some of the economic, recognizing that this loan repayment opportunity could possibly impact people who generally earn, and a provider type that earns significantly less than other types of providers that we have in loan repayment. So without further ado, I'll give the details to our committee leadership, our chair, and our staff members, who I think and hope will do a great job taking it from here. And then certainly in terms of the committee support, have time at the end for questions from the board.
All right, thank you, Brenda. I really appreciate that. Hi, everybody. My name is Kurt Stilp. I'm the chair of the Healthcare Workforce Committee. I've met several of you before when we were talking with you back in February. Of course, a lot has changed since then. And so our presentation today and our slides are really focused on a little bit of the shift that was required of us, that you asked of us, as well as where we are headed into the future. Next slide, please. So this is what we would like to cover in a presentation today. Talk about background and remaining funds, review a little bit of what we covered in February, and then really focus on the bulk of our presentation on the recommendations from our committee, and then rounding out with a little bit of background on the Scholars for Healthy Oregon initiative. Next slide. So just as a reminder, about a year ago, we came to you with some recommendations when it came to funding and making some funding changes to the Healthcare Provider Incentive Program. As a reminder, we added some money to both the repayment and forgiveness programs, kept the Scholars for Healthy Oregon initiative at level funding at $2.5 million, as well as kept level funding for the Shoei-like programs at other universities in the state. We also recommended no change to the rural insurance subsidy program and no change for the current administration funding levels. So just as a background, that was roughly a year ago in October 2019. Next slide, please. In February, as you may recall, several of us made a presentation talking about recommendations for additional funding for the Healthcare Provider Incentive Program. We recommended a couple new programs, including a clinician wellness project, as well as money for a housing incentive project, and a little bit of funding to be added to the repayment and loan forgiveness program, as well as the Showy-like program. As you may recall, during that meeting, there was really several questions and a focus on behavioral health. And so the recommendation to us in the Healthcare Workforce Committee was to go back and reconsider some things, really reconsider the focus on behavioral health. And so we did that in March. We had our last in-person meeting before COVID swept in. And we did discuss the recommendations from you, the board, as well as what we might do going forward. It's a very good discussion. And so the remaining slides really will highlight the recommendations that the Healthcare Workforce Committee came up with that we were ready to present to you, the board, in April, and then have been obviously delayed until now to bring to you. Next slide. And I'm going to turn it over to Mark Overbeck at this time.
Great, thanks, Kurt. Hi, good morning, everyone. I'm Mark Overbeck, the director of the Primary Care Office here at the Oregon Health Authority. This slide is our very favorite bucket chart. And the amounts in green on the left next to each category reflect the status quo in terms of how the monies in the Healthcare Provider Incentive Fund have been allocated based on direction from the board. You'll see over on the right, there's a bucket all by itself in green. And while it actually says 4.2 million, which is the number that we have been working with back in February, for various reasons, including the interest-bearing account and some other under expenses, that dollar amount is actually closer to $4.9 million. But this bucket chart, which you're very familiar with, that identifies the types of financial and non-financial incentives available for Oregon clinicians for recruitment and retention, is displayed here. So we could have the next slide, please. As has been said throughout this meeting, and to state one more time, perhaps the obvious, a lot has happened since February. Our world has really altered. And two things in particular. One, the impacts to the healthcare workforce due to COVID. Dr. Santa just spoke about reduction in utilization, but we're also clear that the need for behavioral health remains very strong, and if anything, probably more important as people are dealing with new stresses in life, as there are just a lot of things that are impacting people and families. And as there have been some mention, and there will be more mention later in the meeting, the Governor's Behavioral Health Advisory Council has met since February, and they've offered recommendations, and they're very clear, and OHA is very clear about the need for support around behavioral health, as was this board when you gave the direction to the committee, go back and do something around behavioral health, try harder. So while we have the impacts due to the pandemic, we've taken the direction to mean, okay, well, fine, things are different, but the need for behavioral health has not changed. And then secondly, the second major impact to Oregon is the revelation since February, March around systemic racism that have not been a surprise to many, but have gotten far more deserved attention. And OHA is doubling and tripling down on advancing health equity, not just as something that we need to consider as we do our job, but as Director Allen says, it is our job. So we're taking all of that into account as we come to you with the revised proposal, which, as Kurt said, we were prepared to bring in April, but feel even more strongly due to these two societal impacts, this is the right proposal. And so if you can have the next slide. The summary of this proposal, and then I'm going to turn this over to my colleague, Joe Sullivan, who actually manages all the funds in the Healthcare Provider Incentive Fund and the program, is rather than do the other things that we had recommended, use up to 2.4 million for a specific behavioral health incentive to do fundamentally three things. One is better ensure that behavioral health professionals from communities that have been marginalized, underrepresented, Native Americans, Black, people of color, Latinx communities, better ensure that those clinicians will be able to take advantage of the funds we have to support recruitment and retention of the health professional workforce. Secondly, expand the existing qualifying sites for the state loan repayment effort to include community-based services as well as day treatment and residential treatment, which has not been the case. And then finally, offer loan repayment to incentivize those QMHAs at a bachelor's level, which have not been eligible to a degree, to be retained where they're needed. So QMHAs would be added to the grouping of behavioral health professionals to be supported under a program. And to provide the details of this proposal, next slide, please, and Joe will walk you through those details.
Thank you very much, Mark. I appreciate that. And thank you, everyone at the board, for having us today and allowing us the opportunity to speak about the behavioral health incentive that we've developed in coordination with some community members, as well as incorporating your guys' feedback and what we've heard from some colleagues at OHA as well. It is our belief as program staff that the expansion that we're talking about today, which is a specific loan repayment option for behavioral health clinicians, would help advance health equity through incentivizing providers who have otherwise been deemed ineligible in traditional programs. And we'll continue to prioritize those from marginal backgrounds, people of color, tribal communities, and those with lived experience similar to those they serve. In regards to the first slide here that you guys can see, our primary focus, much like the other incentives we currently run, is that we will focus on awarding clinicians from diverse backgrounds. That's BIPOC providers, people from tribal communities as well. And this is aimed at developing a workforce that is reflective of the people it serves. We hope that reducing student loan burden for these clinicians can help reduce burnout and achieve greater work-life balance. Of the total awards since the inception of the Healthcare Provider Incentive Program, 30% represent clinicians from BIPOC or tribal communities. Of those who have applied, about 87% of those who identify as non-white have been awarded. We believe that with more targeted outreach and interfacing with community organizations as well as advocacy groups, our hope is that we can reach more clinicians of color and support them through loan repayment. Next slide, please. The next component, and something that I've heard many times on site visits and when working with different organizations that do behavioral health throughout Oregon, is expanding the eligible site criteria to include community-based providers as well as residential and day treatment providers. In traditional loan repayment programs, those run both by OHA and the National Health Service Corps, services must be provided in the clinic for 32 hours of direct patient care per week. One of the aims of this incentive is to remove that barrier so those providers who meet people where they are can be eligible to apply for an award. We also plan to allow providers who are working in residential day treatment settings to be able to apply. This is a large shift from any incentive program currently being operated and would allow access to loan repayment funds where there's otherwise been no option for these type of providers. Making this change would open the door for providers who have reached out to the program in the past but didn't fit the traditional loan repayment requirements. When we've gone on site visits, we've asked mental health clinics, behavioral health clinicians what would be the most helpful for them, and many stated that allowing providers to work in the community would have a very large impact and would allow a larger number of clinicians from their organizations to be eligible to apply. So we believe as program staff that operationalizing this change would open the door for many clinicians who have been interested in loan repayment, but have been otherwise unable to apply due to their service locations or the modalities that they use. Next slide, please. And a further, I think we went one too far. Thank you. So the next component in thinking about a robust behavioral health specific loan repayment incentive was including bachelor's level clinicians to help alleviate some of the burnout we know occurs in behavioral health due to low wages and the difficult work environment. We've heard from many people in the field on site visits and other conversations, as I mentioned before, that student loan debt is a large burden for QMHAs, and a lot of the time it can serve as a barrier to people going and working towards getting their master's and being licensed clinicians. It is our hope that allowing access to loan repayment prior to completion of a master's or enrollment in a master's program could help create an avenue for future licensed clinicians. According to OHA's 2019 Diversity of Oregon's Licensed Healthcare Workforce Report, while the state of Oregon is 77% white, Caucasians represent 90% of licensed behavioral health clinicians. Targeting BIPOC providers and people from tribal communities who apply for from this group of clinicians could help be a key part of creating another pathway for licensed behavioral health clinicians of color, which through the report we know is a gap. I hope that the program and the committee has given due consideration to the advice that you guys had given us back in our February visit, and that you'll vote to approve this funding today to develop a behavioral health specific loan repayment incentive within the healthcare provider incentive program. You can go ahead on to the next slide, and I think I'll hand it back over to Mark.
Thanks very much, Joe. The final component that we're bringing to you is a decision by the board to go ahead and continue historic funding levels for the Scholars for a Healthy Oregon Initiative program at Oregon Health Science and Science University. This program, while funded through the Healthcare Provider Incentive Fund, has its own independent set of statutes. And I think most people are familiar with the program. It enables OHSU students to receive full scholarships in exchange for a service commitment to practice either in a rural or other designated underserved area. As I said, our recommendation is to continue the historic funding level for the 2021 academic year. And OHA has a statutory responsibility to report to OHSU what will be that funding level, such that we're coming to you for that. As I believe the chair mentioned at the beginning of our presentation, here available to answer questions are Dr. David Robinson, the Executive Vice Provost, and Julie Hanna, VP for Government Relations. And I want to make sure that David and Julie, we can see you on the screen and that you're there and available. And perhaps at this point, I'll go back to our committee liaison from the board, Brenda, to see if there's any initial questions that she would like to tee up for our guests.
Thank you. I appreciate that, Mark, and what a great presentation, Kurt and Joe. You all are doing really tremendous work here, so thank you very much. I think my question relative to SHOE is really based in regrounding the board on a couple of questions. The first being the typical way in which the SHOE program distributes awards, both geographically and then relative to the questions of awardees and their demographics. So that, I think, are two questions that kind of go hand in hand. And then my second question is about just again reminding us what the typical size of an award through the SHOE program, what that looks like. So I'll pause here and invite either David or Julie to respond, or anything else you think is really important to call to the board's attention. Thank you.
My name is David Robinson. Thank you to the board, Dean Bandsberg for inviting me, Mark for asking me to come along and just give you a little bit of data. I'm more than happy to answer questions. I didn't really come with a prepared presentation, but I do have some slides that I would like to share with you if from various presentations I've given in the past. If I can share the screen, is that okay?
Steph, is that possible?
I'm about to try.
Okay, go ahead. There you go.
Can you see that right? I'd have to see what I see here. So just so everyone knows, or remind everyone, I'm sure a lot of people on this call actually already know this, but Scholars for Healthy Oregon was established in 2013 And really, as Mark intimated, the goal of the show is to try and increase the number of healthcare practitioners in rural and underserved parts of the state. Essentially, what the Scholars for Health Oregon initiative does is it grants a what we refer to loosely as a full ride scholarship. So your full tuition and fees are paid for the whole length of your course. So for instance, you're a medical student, you get 4 years of tuition and fees paid for you. If you're in the physician assistant program, is a little over 2 years. If you're in one of the nursing programs, obviously that varies, but it's 2 to 3 years depending on which program you're in. And then in return for that, the students who receive these awards all commit to serving the length of their program plus 1 year in a rural or underserved community as defined by the Office of Rural Health's definition of rural and underserved. This data is something we presented to the legislature a little over a year ago now. So it's a little out of date, but it gives you a general idea of the scale and scope as it was as far as the 2018-19 academic year. Obviously, we've only got 19-20 missing. So we've had currently 97 students enrolled. I won't read the slide. You can see the distribution of those, but the important thing here to note is that so far, when these 97 students graduate and enter the workforce, they've obligated 377 years of practice in rural or underserved communities in Oregon. That's a huge commitment, and in return for that, these students essentially have been obviated about $12.4 million worth of debt that they would otherwise have incurred if they'd have paid out of pocket for their own tuition and fees. And I should go back, and I think everyone on this call probably knows, student debt is a big decider in where you practice and what specialties you practice in. And so obviously having no debt really is a great encouragement to enter the workforce in a rural and underserved area of Oregon. I think I'm just going to, hopefully you can see this slide now. This is essentially a distribution of the funds that have been given by disciplines, so medicine, dentistry, physician assistant, and nurse practitioners. And this is actually updated until the current, well, the last academic year. So we've given almost $15 million of grants at this point. One of the questions that was asked was, how big are the awards? Well, that depends on the program you're in. If you're in the MD program, is going to, I'm doing this from the top of my head, so it's not going to be wholly accurate, but it's going to be probably around $200,000. If you're in a nurse practitioner program, that's probably going to be near $60,000. And so the number of students that are awarded or where awards are granted each year varies depending on the number of qualified applicants that we have to the program. Essentially what happens is you have to be admitted to the program first, and then if you qualify and you're interested in working in a rural underserved program, you then apply to the SHOE scholarship. So you have to get into your program first, and then you apply for the scholarship. So this is the general total funding awarded by discipline. Another question that was asked was about the demographics. These are the demographics by gender over the years 2014-15 to 2019-20.
David, excuse me, could you advance your slide? I think you're speaking to a slide we're not quite viewing yet.
Can you see that slide? I did advance my slide in my view. Can you see it now?
We're seeing Scholars for Healthy Oregon, the geographic distribution. We're not seeing the gender.
Oh, yeah. Sorry. Let me try that again. How does that work? Better? Sorry, it said I was sharing my screen, so I just moved from one slide deck to the other. Sorry about that. So this was the breakdown of the $15 million, sorry, I was talking about that you couldn't see, unfortunately. So hopefully I'm going to then, and I can share these slides with you later. This is the demographics. We can hopefully see a histogram at this point of our demographics by gender from 2014 to 2019-20. Then another demographic we have, as you can see, obviously, in most years, we have more females than males in our awards by gender. There was just one year, I think, the last year that changed. And this is awards by ethnicity, focusing on whether Hispanic or Latino or not Hispanic or Latino. And as you can see, the majority of awards are made to students who do not fall into the Hispanic or Latino group, but there are two to four each year that do fall into that particular grouping. There's a little bit more detail about the ethnicity and cultural backgrounds of our students who have been awarded a Shoei of this time period in the next slide. This is award by race. And once again, you'll have to forgive me, I am colorblind, so I'm going to always get the colors wrong, but it looks a little orangey to me, does this big thing in the middle here, but it may not be orange at all. As you will see, if we go look at 2019, there was 17 awards made in 2019-20, of which 9 were provided to applicants who self-identified as white, and then you can see the breakdown by other races here in these numbers here. So, I think, before I go on a little bit further, the one thing I want to mention is obviously these demographics are important. Also, where are our graduates going? So once you've graduated, you then either go on to your residency and then return into the workforce and do your commitment, or you immediately enter the workforce and execute your commitment. So this actually shows where the recipient's home was. So these were the applicants originated from when they applied to OHSU. So you see a fairly good distribution across the state. This is the distribution of the specialties that the graduating students have gone into. And I keep wanting to explain, we haven't had any medicine graduates yet, because not only do they have to do the 4 years of medicine, undergraduate medical education, but they also have to do a residency. And so we should start getting our first graduates coming out this coming year, and we will be able to update this slide accordingly. But they have to go into a certain area of need within a rural underserved area of Oregon. And so you can see the various different types of specialties that graduating students have gone into. Based on the previous conversation, there's just 2 here, nurse practitioners in mental health, and we have 1 physician assistant who's gone into mental health. That's kind of directly related to the behavioral health discussion earlier. And then finally, something that Mark was very eager for us to talk about was, where are these students going when they graduate? And so we created this little table, essentially just showing the towns in which the students are currently practicing across the state, sorry. Usually there's 1 in most of the places. Obviously, someone might say, well, why is Portland on there? Well, you're able to work in a FQHC or some other specialty clinics that serve underrepresented minorities and or underserved areas. But the other biggest one from there is Roseburg. Obviously Salem and Silverton have 2 each. So there's quite a distribution across the state, and obviously once the medical students start graduating, these numbers will fill out even more. So that's kind of the Shoei program with some demographics and distribution. I ran through a lot of data there, and I know we're short on time, so I don't want to keep going, but I'm more than happy to answer any of the questions people might specifically have about Shoei and you know, the future or the successes of the past.
Thank you so much for the presentation. I'll just kick us off a bit with a question around your process for recruiting more students of color and how you go about that, how you contemplate those demographics.
Yeah, well, we put an awful lot of effort into reaching out to increase the diversity of the incoming pathways. It's been a major, you know, thrust for us for quite some time now. I think one of the challenges we have, just like everybody else, someone mentioned earlier, is the demographics of the state. One thing to note is that OHSU tries to provide the majority of its healthcare professional positions in either medical school, dental school, or our nursing programs from Oregonians. And the number of Oregonian, qualified Oregonians who come from underrepresented minority or disadvantaged backgrounds is generally very small, has been historically very small. But we've tried a number of different programs to increase the diversity of our applicant pool. So one of the things that we've shown, or I'm showing here, hopefully you can see now a table that just kind of summarizes some of our the outcomes of our efforts from 2014 through 2018. And as you'll see, our total number of students and fellows and faculty have increased. You know, students, the way you read those arrows is the number of students has increased by less than 10%, but the number of faculty have increased by greater than 10%. And those who self-identify in a minority class in all of those groups have gone up greater than 10%. And if you look at particularly underrepresented minorities, you will see that the increase in our students entering has gone up quite significantly due to some of the efforts of our programs that we do. But some of these programs are very long, take a long time to come to fruition. We spend a lot of time and effort reaching as far back to middle school with a lot of middle school programs. And one of the programs that we put an awful lot of effort in is to something called the On Track program. And this actually is in collaboration with Jefferson High School. It's part of the Portland Public School System, Woodburn High School, Confederated Tribes of Warm Springs, and also the Chiloquin tribe down in Klamath Falls. And what we have is we have specific programs that start in the middle schools that serve those high schools. And we keep in touch with the students from 6th grade all the way through graduation. And then we actually keep in contact with them through their degree programs. And actually we help enroll them into various kind of summer internship programs and ongoing enrichment programs at OHSU to try and keep their interest in both STEM, which is the first thing. And then obviously if they're interested in STEM, are they going to be interested in entering the healthcare workforce? And this has been very successful. In fact, we have our first middle school student that we interacted with many years ago is now just applying to OHSU's medical school. We do have students who are already applied and been successfully entering our nursing school. So it's actually a pretty successful program. And this is one of the reasons we're actually seeing an increase in diversity in our incoming class. The other thing we're doing is to attract a more diverse class is we're redirecting money that we have at OHSU to create our own scholarships. We call these the presidential scholarships. And these are given out, created in 2012. And these are given out to students from racial or ethnic groups or underrepresented in healthcare professions. We also give them to people who come from rural environments and people who have experienced significant disadvantage in their life somewhere along the way. Since 2012, we've given out 72 of these. They're also full ride scholarships, very similar to Shoei. There is no service obligation attached to these. So these students, once they've graduated, graduate without debt, and hopefully make decisions to work and support the areas and rural environments they've come from. And so this represents about $8.2 million investment. And this is used for recruitment. We actually announce these. If you come to OHSU and you get in, you may be able to apply for these scholarships. And it's very attractive, obviously, to students to apply. So that's one. So these are a couple of the reasons why we've seen such an increase in the diversity of our incoming class. There's an awful lot more work to do. And I'm only talking about 2 of the programs we have here just to give you a highlight, but it's something that OHSU's fully committed to, and it's something we have to do in order to serve the health needs of all Oregonians.
Thank you, David. Thank you, Brenda. We should probably close the discussion, move towards a vote. Brenda, any other closing comments you want to raise for the board?
No, again, thank you for that detail on Shoei, and we look forward to more conversations around the alignment of those kinds of initiatives. So thank you very much, David and team. I believe, Dr. Bangsberg, to your point, you're looking for a motion from me, yes. Or perhaps another board member on the approval of the redirection of the healthcare provider incentive program to support the new behavioral health initiative. So moved.
We have a second.
Second.
And I just also want to note that we have public testimony submitted by the Tri-County Behavioral Health Association in strong support of this measure. I think we'll hear from them later in the public comment, but they submitted some written testimony which I reviewed, and I think we're very engaged in this decision and fully supportive. Any other discussion before we have a vote? Should we do a roll call, or just all in favor say aye?
Aye.
Aye. Aye. Any opposed? And any abstain? Great. So the proposal is approved by the board. Thank you very much. I also would just want to recognize all of you, Kurt, Mark, Joe, for listening very carefully to the board's deliberation, going back, doing more work on this and bringing this back. And thank you, Brenda, for your leadership on this area. It's really nice to see this discussion evolve and see this come back to maintain this as as important priority for the state, especially during this time. And really, your comments are really very well taken. And so thank you very much for your responsiveness.
Thank you.
And for the extra work. All right. Let's move on. We're pretty close to on time. We have a discussion on health plan quality metrics committee, where we will have a vote on member appointments. This will be presented by Stacy Schubert, the Director of Health Analytics.
Hi, can everybody hear me?
Yes.
Excellent. I feel like I should start with a joke, but maybe that's not appropriate. But I keep thinking.
It's okay with me.
I should say I'm back, because I've been on this so many of your last meetings, which is a reference to The Shining, and you all know has an Oregon connection. So very exciting. So I'm really excited to be back today, talking to you again about metrics. It's a little bit different aspect of the metrics. So today I want to talk to you about the Health Plan or Health Plan Quality Metrics Committee. I'll call it the HPQMC for short. So you may or may not know that in 2019, House Bill 2265 amended the original statute that created the HPQMC, and it gave you all the authority to review and approve HPQMC committee appointments effective January 1st of this year. We're a little bit late in coming to, because of course everything is topsy-turvy this year, to get these committee appointments made, but the good news, I guess, the silver lining is that HPQMC actually hasn't been meeting for quite a while. So we're not late from that perspective. So today I'm going to talk about, I'll give you just a very brief overview of HPQMC on the off chance you haven't been following the work that they do. I'll talk about the member appointments for which we're seeking approval. I'll highlight a few of this committee's major accomplishments since it started in April of 2017, and then we'll have time for questions. So I do want to draw your attention to, in the packet, there is a summary. It's number 5, and I believe Tara sent out an updated version last night. So it is the updated version, not the original one. So there's a summary of the 10 members for whom we are requesting reappointments and 1 new appointment. You can also see for your reading pleasure a blank HPQMC membership application and the Real D questions that are asked of every member, and then a current committee roster with the member bios. So next slide, please, Michelle. So Senate Bill 440 originally in 2015 established the Health Plan Quality Metrics Committee as a committee that's the responsible entity to align health outcome and quality measures used in this state. It's charged to identify health outcome and quality measures that may be applied to CCOs, health benefit plans sold or offered on the Health Insurance Exchange, OEB, Oregon Educators Benefit Board, and or the Public Educators Benefit Board, PEB. And secondarily, to evaluate the health outcome and quality measures adopted on a regular and ongoing basis. The health plan, next slide, please. Sorry. The Health Plan Quality Metrics Committee has 15 members, and their appointments are, as I mentioned already, now reviewed and approved by you guys. The committee works in tandem with the Metrics and Scoring Committee. So they're really enmeshed. The HPQMC defines the universe from which Metrics and Scoring Committee can select the quality incentive metrics for CCOs. Next slide, please. So this slide, in a very simple way, shows the relationship among the Health Policy Board, the HPQMC, the Metrics and Scoring Committee, and the CCO Metrics Technical Advisory Group. As you can see, HPQMC is a committee of the board, and as such, accepts guidance from you. And the Metrics and Scoring Committee is a subcommittee of HPQMC. But as I said, Metrics and Scoring and HPQMC really work in tandem with one another or in partnership with one another. And an example of that is that the Metrics and Scoring Committee may recommend that HPQMC consider putting measures on the measure set. And that's because if a measure isn't on the larger measure set that HPQMC develops, then Metrics and Scoring can't select it as an incentivized measure. And then the CCO Metrics Technical Advisory Group advises Metrics and Scoring Committee. So next slide, please. Committee membership roles are defined by the statute. You can see here what those seats are. There are 12 different buckets, essentially, and some of those buckets have more than one representative who sit on the committee. There are a couple of noteworthy things, not that we necessarily need to do anything about it at the moment, but I just do want to note that there is no dental health provider role. And there is no designated voting member representing the Metrics and Scoring Committee that sits on the Health Plan Quality Metrics Committee. Per the bylaws that were updated in January of 2020, however, Metrics and Scoring Committee will have a committee member at the HPQMC table, but it will be a non-voting member. Okay, next slide, please. So as you can see in your packet in Table 1, there is one new appointment recommendation, and that's for the position representing the Department of Consumer and Business Services position. And Katie Button is the individual who was recommended to serve in this position by Department of Consumer and Business Services. Below that in the table, you can see the 10 existing committee members for whom OHA is seeking reappointment. We feel that reappointing these committee members will allow for continuity on the committee. And then even after these appointments, there does remain one committee seat that is vacant. That seat was relatively recently vacated, so we have not had a chance to conduct a thorough search to fill it. And that seat represents insurers, large employers, or multiple employer welfare arrangements. So we are currently recruiting to fill this vacancy. Next slide, please. So I do want to talk a little bit about some of the major accomplishments that this committee has contributed over the past 3 years. In specific, I'll draw your attention to 2 of them. The first one was the approval of the initial aligned measure menu set in May of 2018 at the top of the slide. The committee reviewed 117 measures and winnowed it down to approve 51 measures for inclusion in the original measure set. So that's, I think, very impressive. I was not a part of that work. I imagine it was pretty hard though, and took a lot of dedication. The second big accomplishment that I would like to draw your attention to is the February 2020 bullet. So at that time, the committee approved selection criteria for measures that may not have national endorsement, but address priorities and gaps specific to Oregon. And that's very important as we move toward the work and into the work, and we embrace the work that we need to do on health equity in the state. You all may or may not be aware that we did try to find health equity measures to adopt. The Health Plan Quality Metrics Committee tried to find health equity measures to adopt, and there were not any available nationally. And so we had to really think creatively and come up with a potential solution that was to some degree untested. And in order to be able to select that metric and other metrics like it, the Health Plan Quality Metrics Committee had to think creatively about the selection criteria for allowing such metrics to be included on the measure set. So the adoption of these somewhat more flexible criterion allowed 2 measures that were developmental to be included on the measure set in March. And one of those, as you know, the health equity measure, was selected by Metrics and Scoring Committee for inclusion in next year's CCO quality incentive program. So those are, I think, two really big accomplishments. So next slide, please. So this slide highlights activities and deliverables in the next committee cycle and beyond. Between October of this year and April of 2021, the committee will need to approve the 2022 aligned measure set, and that needs to happen by the end of April. And they will elect a chair and a vice chair. Between April 2021 and April 2022, the committee will approve the 2023 aligned measure set and also be reviewing the list of measures to be in alignment with health equity and OHA strategic goals. And we will have changes in committee membership. So there's a lot in store for HPQMC. It's very important to have committed members. I have been incredibly impressed with the dedication of the members that we currently have. I'm very excited to get started with meetings again with these members, and I hope that you guys will approve the recommendation that OHA is promulgating for reappointing and newly appointing the members in your packet. And next slide, I just want to see if anybody has questions.
Thank you. Zeke, you had a question?
Thank you, Chairs Bangsberg. I actually have 3 questions, and I'll ask them all, and if you want me to repeat at any point, that's okay. One.
I might want to write them down.
Sure.
Go ahead.
One, I'm interested in what thought or attention you all have put to the demographic background of the committee. When I look at the existing committee, it seems pretty underrepresentative of individuals by multiple demographics that we care about in terms of underserved populations as well as geography. 2, I'm wondering if you put any thought into the wanting to, we're gonna run into the same situation where next year you've got 10 people up again or 11 people who are up for reappointment, and whether there's a value in thinking about kind of where people, I don't quite understand the 2 years versus the 1 year process, but like if there is a distinction there, whether there's a value in having alternating groups of people come through. And then the third question I had is escaping me at the moment, but I imagine I'll think about it and I'll come up with it. But if you could respond to those 2 questions.
Yeah, absolutely. I really appreciate your questions. We have thought quite a bit about the representativeness of the committee and agree with you that it could be more representative in terms of geography, in terms of race, ethnicity. We are, I think, doing a much better job now, or we're being much more intentional, maybe I should say it that way, today, and really over the last, I'd say, year, maybe year and a half, in terms of outreach to recruit for committee membership. And I feel a little uncertain. I don't want to say anything that isn't accurate, but I believe that we have worked with OEI potentially, and I know Kristen is on the call, so she may IM me and correct me if this is wrong, but I believe we may have reached out to the Health Equity Committee as well for recruitment. So we're really trying to get the word out in a variety of different ways and do what I think of as snowball recruiting. So where we speak with community leaders and ask them for recommendations. And you will see, for instance, if you look at the composition of the metrics and scoring committee, that's changed quite a bit over the last year or so. And that's a consequence of that. The thing that's different about Health Plan Quality Metrics Committee is that it's a much newer committee. And when it was started up, and this we'll start to move towards the second question you asked, Zeke, we filled 15 seats at that time. The way the committee membership works is people are appointed for initial 2-year terms, and then they can re-up for single years for up to 2 more years. And that's the same way it works for metrics and scoring committee. As a consequence of that, it means that because we're still not very far into the life of this committee, we have many of the members are the same members that we started with. when we first recruited, and before we were using those more more equity-centered recruitment techniques. So we certainly have that in mind. It's a priority. Go ahead.
So if I understand correctly, let's say, so there are 10 folks that are being recommended for reappointment. If 5 of those were newly seated individuals, that would mean that the 5 who are currently seated would be up again in a year, and that will be at the point at which they're expired. The other 5 who were new would actually have 2 years in their initial term, which would set up then potentially where you've got rolling 3 to 5
Correct.
people in each given year.
Correct. And yes.
Great. Then I remembered my other question. My other question was, I'm just, I know that this is a list of individuals that were appointed by the governor, but I'm just interested in the 2 people representing healthcare consumers. They look like wonderful individuals. They're also clearly healthcare professionals, which does not, in my mind, align with the spirit of what those positions are really about. So I'm just wondering if there was any thought put to that.
Yes, we absolutely put thought to that. I think, again, this is an area where we, to some degree, I would say, struggle. We have the same challenge with the metrics and scoring committee. To have somebody who's truly a community member it will take us quite a bit of work, and we certainly have tried to find somebody who's truly a community member. I believe right now we are working with CCOs to see if they can recommend people who are Medicaid recipients who would be interested in serving on the committee. I think another challenge that I have noted, I believe this only, I'll have to check and correct myself if I'm wrong about this, but I believe it only refers to HPQMC, where we are not allowed to pay people for their time by within the statute. And I feel like that is an impediment to getting authentic community voice on a committee. So that's something that I've talked about trying to address. However, it's a statutory change. So it's something that we would need to decide was worth reopening the statute for.
Thank you, Zeke. I think Vice Chair Arana had a comment as well.
Yeah, thank you. You know, when I was reading the materials and I was looking at this, the comment that kept coming to mind was nothing about us without us. And that's kind of how it feels, right? There's no actual representation from the consumers in these committees that make some very important recommendations that impact their lives. And it's, you know, when it sounds like there's some things that would really have to change to be able to achieve that. And I agree that being able to provide stipends for folks to participate, or figuring out how can we lift sort of some of these restrictions to get their voices and make it easier for them to participate is something that we should be really considering and looking at. Because I just, you know, I've been on this board for many years, and we keep having these slates of committee members to approve, and we keep bringing this up over and over again to really focus on more, bringing more racially diverse and geographically diverse sort of slates. And we continue to sort of get the same sort of hear the same sort of comments that it's really difficult, it's really hard. We're making progress, which again, I know I know all of this is really difficult, and I appreciate some of the progress that's being made. It just doesn't feel like it is enough, or that it's moving fast enough, and that we really need to do something different right now.
I hear your concern, and I appreciate that. I do want to check. Steph is telling me that my video isn't working. Can other people see me?
I can see you, yeah.
Oh, okay. Okay. I think, to your point, Oscar, I think that if this had been a normal year, and we had been meeting as we typically do with HPQMC and with Metrics and Scoring Committee, we might be handling these appointments a little bit differently. But it was not a normal year. It's not a normal year for committee activity, for recruitment, or anything. And so we felt like for this year, to hold steady was probably the best solution. I also do want to point out, and again, this isn't, you know, I kind of hate to do this because I don't want this to sound like an excuse, but we do have specific representation on the committee that by statute needs to be there. So representing certain types of entities. And so that's another layer of complexity that comes into recruiting for these positions. But I would say that my team and I could not be more committed to increasing the diversity on Health Plan Quality Metrics Committee. And like I said, on Metrics and Scoring Committee, we actually have increased the diversity pretty substantially over the last year. So I feel confident that we can apply the same principles and achieve the same with Health Plan Quality Metrics Committee. To your original question, or your second question, Zeke, that you asked about essentially staggering the appointments, I think that is, I think that's a great idea. That's something that we've already talked about for the future. It just is not terribly functional for a committee to have all new members every 4 years or so. So we are already thinking about through natural attrition and or potential not suggesting reappointments, potentially staggering, so it is maybe a third each year that we appoint, and that would create a little bit more turnover opportunity to recruit for folks who represent greater diversity.
We should
I know it's not fast enough.
We should probably move forward towards a vote.
Can I ask one quick question, David?
Yeah.
Apologies. Steph, you talked about needing a statute change or maybe you weren't proposing a statute change actually, but the statute is limiting in both the composition and prohibits payment to community members or whatever, those who need it. Is there any intention to request a change to that, or do we just say those are the confines? That's something that I would discuss with Jeremy and Pat. Opening a statute is always comes with risk, right? And so we need to balance that potential risk with the potential gain. And I mean, if it's something that we could characterize as housekeeping potentially, and keep it, not make it be such an opportunity for other modifications, I think that would be great. So
we will talk about that. And like I said, I don't remember, simply because I don't have it in front of me, whether it's actually metrics and scoring where that's the case or HPQMC, but it's one of those two statutes. And both of those committees do have a spot for a consumer representative.
Thank you, Kirsten. Let's entertain a motion for a vote.
So moved. We accept the staff recommendation.
Second. What are Robert's rules if there's not a second? Any further discussion? I think we've heard some concerns. I mean, Zeke, you want to, and Oscar, sum up your concerns, and I could add to that.
Yeah. Thanks, David. If there was a second, I would be voting no on the motion. I'll explain why. I want to acknowledge, I definitely recognize that there are a number of complexities here. I don't know that the legislators really considered the implications of a committee where you have a 2-year appointment and then you have these 1-year extension opportunities, and what that means in terms of trying to find people who both are from the selected set of positions or places that they need to be representing, and then also have the expertise and the time and the ability to be able to engage. So I recognize that. I also recognize that that there are so many different representative agencies or perspectives that are required there, that is another complexity as well. And I made a commitment pretty early on in my time on this board that I wouldn't approve of appointments that don't move us in the right direction around the kind of representation that is needed to really support relationship between the work that the Oregon Health Authority does and that we all care about in communities, and the influence and impact that these kinds of boards have. And I don't see that in this. I also think if there is an interest in staggering, now's the time to do it, because otherwise you're going to end up in a position next year where you've got at least 10 new people coming on who will be for 2 years. And so I just think the complexity of the staggering process, it's either now or it's really hard to get on some sort of a cycle there. And as my question inferred, I am concerned that the 2 consumer representatives don't really represent what I think is intended by the legislation, recognizing again that these were all individuals that were put into their seats by the governor appointment. So I recognize the challenges that the staff is in, and I wouldn't be in a position where I would vote yes at this point for reappointment of these 10 individuals.
John?
Yeah, I think this is an important discussion. It's a healthy discussion, and it's a very valid concern. Zeke, the alternating issue is a big concern. Actually, HPQMC, as some of you may recall, turned down the initial equity proposal, and they did so right in the middle of a transition that was unavoidable. And so I think sorting that issue out is important, and my sense is that can be done. Let me be honest with you. I've done this in my private life. It's very hard to recruit genuinely true consumers. The economic issue is real. All of these other committee members are essentially, they're being paid, so they're not giving up time at work. And that's a huge ask. And this is a very intensely involved committee, in person, where you're expected to be there. If not, you're on the phone. It's, a lot of prep work. I have actually tried to help recruit, and I failed. I've especially tried to get younger folks to do this. And I've been, you know, frustrated when they've turned to me and kind of gone, yeah, nah, you know, not going to do this. So I just want the committee to know this is very tough recruiting work. And, you know, these are a group of people who really are trying hard. These are the pioneers in this performance measurement approach. And, you know, I'm scratching my head. So, you know, what's the staff supposed to do next if this doesn't pass? I think the point's been made how concerned we all are.
To me, what this feels, it's more of an actual systemic sort of barrier here. And I think for me, I would personally feel irresponsible to continue just, you know, approving these, hoping that eventually things will get better. We've been talking about this for many years. This isn't something that's new. So to me, I feel like I would probably vote no to hopefully send a message about trying to shift sort of these systems and these policies that have been made by folks that are not the consumers or that don't reflect like the recipients of these services.
And Pat.
Really appreciate the discussion on this. couple of thoughts occur to me. One, I think I do need to, I guess, defend our honor a little bit in that I do think we've actually made quite a bit of progress in this area across the full range of appointments, committees, advisory bodies, and those kinds of things. So I don't want to let slide the notion that, you know, nothing's happened over a long period of time, because I don't believe that to be true. I do think we have some pretty unique challenges in this area that Zeke acknowledged around the incredibly detailed specificity of the roles that we need to fill, and the nature of the work. If any of you have a neighbor who would love to, you know, spend time on this and want to let us know who that person is, that would be really helpful. Because I mean, from a consumer standpoint, trying to find somebody who is honest to God a consumer who wants to take several hours out of a day for free is as John observes, is a really tall order. I think maybe what might be the most useful thing for us to do is to take this back, come back next meeting with first a little bit of information about how are we doing in terms of our appointments to advisory bodies and those kinds of things, to give you a fuller picture of what that looks like, and see if we can work on some sort of a plan, particularly on the consumer side, to see if we can do anything at all to try to address that. Would that be a useful next step for us to follow?
Thank you, Pat. And I'd have to say I concur with Zeke and Oscar's comments. And you know, I think the consumer issue is real. Obviously, the diversity of the community is real, both geographically and with race and ethnicity. And you know, this is a important challenge. And I think our most important decisions are the ones we don't have consensus on. And, you know, I think that's the best discussion we have. So I really embrace the difference of opinions, and especially on a complex issue like this.
If I might.
I'd like to throw in, and I think the conversation is moving us in the right direction. I also think our board holds a responsibility of letting OHA staff know what success looks like. And I think that we can measure progress in sort of these incremental stepwise fashions, or we can also sort of say, what is the outside reach? And I don't know that we've actually done that in a way that addresses the level of complexity that we're talking about today. So I very much look forward to you, Director Allen, coming back with some recommendations around how we can think about this, not just for this specific committee, but all committees, and then secondarily for the composition of our own board. So that would be a really helpful conversation. Thank you.
And I think reaching out to CCO directors for consumer recommendations is a strong, really good idea. So in the absence of us, Zeke, you want to?
Sorry to interrupt. Just a couple of parting thoughts. I think Pat, that makes a ton of sense to bring that forward, as you said. I think that's valuable. I also just want to acknowledge none of what has been raised as challenges today are new challenges either, nor are they just challenges that we face in this place. We ask our CCOs to have consumers on a consumer advocacy council, and we hold them to it to some degree, I think. So there's that. I also think a number of other times when faced with similar issues in terms of consumers, people have looked to organization. If it is that challenging to get an actual consumer alone, then people have looked to advocacy organizations for those consumers, whether that's Osberg, whether that's some of the community-based organizations that we may be engaging at this point in the contract tracing work or otherwise. So I think thinking about where there are other opportunities to look to fill as close to the spirit of the law, really, I think, or the spirit of the intent behind the law. And then I also would say, I see the challenge with those representatives from all those different places, and yet if those organizations that fill those boxes were pulled in to be a part of the process of identifying people who both represent the demographic diversity of our state, but also can represent those institutions, that might be a way to be thinking about it differently. And I just want to lastly say I appreciate your comment just now, Brenda. I hope that the board is in a position moving forward to give some more explicit perspective and guidance on what it is that the board is looking for. And I am remiss that I will not be a part of those conversations moving forward, because that sounds like a really important role for the board.
So I think in the absence of a second to the motion, we will table this and revisit this with a motion not yet passed. All right, we have a break. Thank you, Stacy. We have a break. We're a little bit behind, but we have no public comments yet scheduled, so we have 10 minutes free in the schedule. Steph, when should we come back in 5 minutes? We'll come back at 10:47.